This case illustrates a classic presentation of secondary syphilis and demonstrates why syphilis is called the great imitator. Our patient is a 20-year-old man presenting with what he believes is an allergic reaction, but the clinical picture tells a very different story. He's had flu-like symptoms for 4 to 5 days, including fever, chills, headache, and body aches. These constitutional symptoms are characteristic of secondary syphilis, when treponemes have disseminated throughout the bloodstream and cause systemic infection. The rash appeared yesterday and is described as diffuse, red, slightly raised bumps covering his entire body. Most critically, the rash involves his palms and soles. This is the diagnostic hallmark of secondary syphilis. While many viral rashes can cause diffuse eruptions, very few involve the palms and soles. When you see a maculopapular rash on the palms and soles, secondary syphilis should immediately come to mind. Now let's consider the historical clues. He was treated for gonorrhea 2 years ago, indicating he's sexually active and has had unprotected sexual contact. This places him at risk for other sexually transmitted infections. More importantly, he recalls having a painless sore on his penis a few months ago that resolved spontaneously after a few weeks. This is a textbook description of a primary syphilitic chancre. The key features are all there: genital location, painless, and self-resolving after 3 to 6 weeks. He didn't seek medical attention because it didn't hurt and went away on its own. This is exactly why primary syphilis often goes undiagnosed, allowing progression to secondary stage. On physical examination, he has generalized lymphadenopathy, involving cervical, axillary, and inguinal nodes. Painless lymphadenopathy is another classic feature of secondary syphilis, reflecting the widespread dissemination of treponemes. The skin examination confirms an erythematous maculopapular eruption covering his entire body, including palms and soles, with no vesicles. The absence of vesicles helps rule out viral causes like chickenpox or herpes. His current genital examination is normal, which makes sense because the primary chancre healed months ago. This timeline fits perfectly. Primary syphilis with the chancre occurred a few months ago, followed by a latent period, and now he's presenting with secondary syphilis approximately 4 to 10 weeks after the chancre appeared. Let's begin by understanding the basic structure of Spirochetes, the family to which Treponema pallidum belongs. Spirochetes are fascinating bacteria with several unique features that set them apart from other bacterial groups. First, they are extremely thin and helical in shape. In fact, they're so thin that they cannot be visualized using standard light microscopy techniques. Think of them as microscopic corkscrews, long, slender, and spiral-shaped with pointed straight ends. These organisms have a gram-negative cell wall structure, which means they have a thin peptidoglycan layer surrounded by an outer membrane. However, you won't be able to see them with a standard gram stain due to their thinness. One of their most distinctive features is their unique method of movement. Spirochetes are highly motile, but unlike other bacteria that have external flagella, Spirochetes have periplasmic flagella, also called endoplasmic flagella. These flagella are located in the periplasmic space between the inner and outer membranes. This unique flagellar arrangement gives Spirochetes their characteristic corkscrew motility. They move by bending and rotating their entire body, and they can adjust their movement according to the viscosity of their environment. This is incredibly important for pathogenesis because it allows them to penetrate viscous tissues and mucous membranes efficiently. Imagine trying to drill through thick mud. That's essentially what these bacteria can do in our tissues, and this ability is crucial for their invasion of the host. As we mentioned, these organisms are too thin to be seen with a standard light microscope using gram stain. So how do we visualize them? The answer lies in special staining techniques, particularly silver staining. Silver staining methods include the Levediti stain and the Warthin-Starry stain. These techniques work by depositing silver particles on the surface of the bacteria, effectively increasing their thickness and making them visible under light microscopy. When you look at tissue sections stained with silver stains, Treponema pallidum appears as brownish-black organisms with their characteristic spiral shape. The silver deposits create enough contrast and thickness for the bacteria to be visible under the microscope. These staining methods are particularly useful for examining tissue biopsies from patients with suspected syphilis, especially in cases where we want to confirm the presence of the organism in tissue samples. However, in clinical practice, we rarely use these histological methods as our primary diagnostic tool because they require tissue biopsies and are time-consuming. Instead, we rely more heavily on serological tests and, when available, dark-field microscopy for direct examination of lesion material. Dark-field microscopy is a special optical technique that illuminates the specimen from the side rather than from below. This creates a dark background against which unstained organisms appear bright and clearly visible. It's like looking at dust particles in a beam of sunlight. The particles become visible because of the way light scatters around them. When examining fresh specimens from syphilitic lesions using dark-field microscopy, you can actually observe live organisms moving with their characteristic corkscrew motility. This direct visualization method is most useful during the primary and secondary stages of syphilis, when organisms are abundant in lesions. However, dark-field microscopy requires expertise to perform and interpret correctly, and the equipment isn't available in all clinical settings. Additionally, other non-pathogenic spirochetes can sometimes be present, particularly in oral lesions, which can lead to false positive results. For these reasons, dark-field microscopy is less commonly used today, and we rely more on serological testing. Let's explore the probable virulence factors that enable this bacterium to establish infection and evade our immune defenses. First, the corkscrew motility we've discussed isn't just interesting, it's a crucial virulence factor. The ability to move efficiently through high-viscosity environments without impediment allows Treponema pallidum to penetrate intact mucous membranes and invade host tissues. This is how the organism can establish infection, even through apparently undamaged skin and mucosa during sexual contact. Second, Treponema pallidum produces hyaluronidase enzyme. Hyaluronic acid is a major component of the ground substance between cells in our tissues. By breaking down this ground substance, hyaluronidase facilitates the dissemination of the organism throughout the body. This explains how syphilis can spread from the initial site of infection to become a systemic disease. Third, the organism expresses adhesins on its surface that can bind to host fibronectin. Fibronectin is a protein found throughout our connective tissues and on cell surfaces. By adhering to fibronectin, Treponema pallidum can attach directly to host tissues. More importantly, this interaction helps the organism evade the immune system and even survive inside phagocytes that would normally destroy bacteria. Finally, and perhaps most remarkably, Treponema pallidum expresses very weak antigens on its surface. Its outer membrane is rich in lipids but poor in proteins, making it difficult for the immune system to recognize and mount an effective response. This is why infected individuals can harbor the organism for years, despite having active immune responses, leading to the chronic nature of untreated syphilis. Syphilis is unique among bacterial infections because it progresses through distinct clinical stages if left untreated. Understanding these stages is crucial for diagnosis and management. Let's walk through the natural history of syphilis infection. The disease begins with primary syphilis, which occurs approximately 3 weeks after initial exposure, though this can range from 10 to 90 days. The hallmark of primary syphilis is the chancre, a painless ulcer that appears at the site where the treponeme entered the body. This is most commonly on the genitals but can occur on the lips, mouth, or anywhere the organism gained entry. The chancre is typically firm, round, and painless, which distinguishes it from many other genital ulcers. Even without treatment, the chancre will heal within 3 to 6 weeks, but this doesn't mean the infection is gone. The bacteria have simply moved deeper into the body. If untreated, the disease progresses to secondary syphilis, usually 4 to 10 weeks after the chancre appears. This stage is characterized by systemic spread of the organism through the bloodstream. Patients develop a rash that classically appears on the palms and soles. This is a key diagnostic feature. They may also experience fever, malaise, lymphadenopathy, and mucus patches in the mouth. Secondary syphilis can also present with condylomata lata, which are wart-like lesions in moist areas. After secondary syphilis resolves, patients enter latent syphilis. During this stage, there are no clinical symptoms, but the infection persists. We divide latent syphilis into early latent, less than 1 year, and late latent, more than 1 year. Patients remain infectious during early latent syphilis. Continuing with the stages of syphilis, let's focus on what happens in the late stages and the timeline of disease progression. The latent stage can last for years or even decades. During this time, the infected person has no symptoms, but serological tests remain positive. Approximately 1/3 of untreated patients will progress to tertiary syphilis. Though with modern antibiotics, this stage is now rarely seen in developed countries. Tertiary syphilis can manifest in several devastating ways. It typically develops 10 to 30 years after initial infection. There are 3 main forms. Gummatous syphilis involves the formation of gummas. These are destructive granulomatous lesions that can affect soft tissues, bones, and internal organs. They appear as nodular lesions that can break down and cause significant tissue destruction. Cardiovascular syphilis affects the heart and major blood vessels, particularly the aorta. It can cause aortic aneurysms, aortic valve insufficiency, and coronary artery stenosis. These complications can be life-threatening. Neurosyphilis can occur at any stage, but is most common in tertiary syphilis. It can present as meningitis, stroke-like syndromes, dementia, general paresis, or tabes dorsalis, affecting the dorsal columns of the spinal cord. leading to loss of proprioception and coordination. It's important to note that congenital syphilis occurs when treponema pallidum crosses the placenta from an infected mother to her fetus. This can result in stillbirth, neonatal death, or infants born with various abnormalities including saddle nose deformity, Hutchinson's teeth, saber shins, and eighth nerve deafness. This is why screening pregnant women for syphilis is a standard part of prenatal care worldwide. The source of treponema pallidum is exclusively humans. There are no animal reservoirs. The primary mode of transmission is sexual contact. Treponema pallidum is transmitted through direct contact with infectious lesions during vaginal, anal, or oral sex. The organism can penetrate intact mucous membranes or enter through microscopic breaks in the skin. Remember, the chancre of primary syphilis and the lesions of secondary syphilis are highly infectious. Vertical transmission from mother to child occurs in utero when the organism crosses the placenta. This can happen at any stage of pregnancy, but is more common when the mother has primary or secondary syphilis due to higher bacterial loads. Congenital syphilis remains a significant problem in areas with inadequate prenatal screening. Blood transfusion was historically a mode of transmission, but this is now extremely rare in developed countries due to mandatory screening of blood donors for syphilis antibodies. However, in regions where blood screening isn't universal, this remains a potential risk. Let's explore the pathogenesis of syphilis in detail. The infection begins when treponema pallidum penetrates the skin or mucous membranes during sexual contact. The organism multiplies locally at the site of inoculation, and this multiplication triggers an inflammatory response that results in the formation of the chancre, the characteristic lesion of primary syphilis. The chancre appears typically after an incubation period of about 3 weeks. One of the remarkable features of treponema pallidum is its ability to evade immune recognition, both humoral and cellular immunity. This evasion is largely due to its outer membrane, which is extraordinarily rich in lipids. This lipid-rich surface effectively masks the organism from antibodies and immune cells, allowing it to persist despite the host mounting an immune response. From the primary site, the treponemes invade local lymph nodes and then disseminate into the bloodstream, marking the transition to secondary syphilis. The ability to traverse endothelial cell monolayers is a critical virulence factor. The organisms can slip between the tight junctions of endothelial cells without causing major disruption, allowing them to spread throughout the body. Regardless of the stage of disease or the location of lesions, a characteristic pathologic finding in syphilis is plasma cell-rich mononuclear infiltrates in the dermis. This inflammatory infiltrate is part of the immune response, but also contributes to tissue damage. In secondary syphilis, you'll see lesions like condylomata lata, which are wart-like lesions that occur in moist areas. Treponema pallidum can involve many visceral organs during secondary and latent stages. The organism can be found in the liver, kidneys, eyes, and other organs, though clinical manifestations may not be apparent. In tertiary syphilis, we see infection and inflammation of blood vessels, particularly in the central nervous system and cardiovascular system. This leads to the formation of gummas. These are destructive granulomatous lesions that can affect soft tissue, cartilage, internal organs, and bone. A crucial concept to understand is that much of the damage in syphilis occurs primarily because of the host immune response to the infection, involving both humoral immunity and cell-mediated immunity. The chronic inflammatory response attempting to clear the organism actually causes the tissue damage we see clinically. We have two main approaches diagnosing syphilis: direct evidence of the organism and indirect evidence through serological testing. Let's start with direct methods. Direct evidence means we're actually detecting the presence of treponema pallidum in lesions. This is the most definitive way to diagnose syphilis, but it's only possible when active lesions are present. The primary method for direct detection is dark field microscopy or immunofluorescent staining. Dark field microscopy, which we discussed earlier, allows us to visualize live, motile treponemes from fresh specimens. Immunofluorescent staining uses fluorescently labeled antibodies specific to treponema pallidum, which bind to the organism and make it visible under fluorescent microscopy. For direct detection, we need appropriate specimens. During primary syphilis, we can collect exudate from the chancre. The surface of the chancre is gently cleaned, and then the base is abraded to produce serum, which is examined immediately. During secondary syphilis, we can obtain material from skin lesions, mucus patches, or condylomata lata. It's important to note that treponema pallidum cannot be cultivated in the laboratory using standard culture techniques. This is a significant limitation because culture is our gold standard for diagnosing most bacterial infections. The organism is extremely fastidious and requires very specific conditions that we cannot replicate in laboratory culture media. Because of the difficulty in culturing the organism and the limited availability and expertise required for dark field microscopy, most clinical diagnosis of syphilis relies on serological testing rather than direct detection. However, when available, Direct detection provides immediate and definitive diagnosis during early stages of infection. Since direct detection of Treponema pallidum is often impractical, we rely heavily on serological tests, detecting antibodies in the patient's serum that indicate current or past infection. Let's explore the first category, non-treponemal tests. Non-treponemal tests include the VDRL test and the RPR test. These are called non-treponemal because they don't actually detect antibodies against Treponema pallidum itself. Instead, they detect antibodies called reagin. Reagin antibodies are produced by the body in response to lipid materials released from damaged cells during syphilitic infection. Specifically, these tests detect antibodies against cardiolipin, which is a normal phospholipid component of cell membranes. When tissues are damaged by the syphilitic infection, cardiolipin is released, and the immune system produces antibodies against it. The VDRL and RPR tests are classified as nonspecific tests because these antibodies aren't specific to syphilis. They can also be produced in response to other conditions that cause tissue damage, such as pregnancy, autoimmune diseases like lupus, other infections, and even advancing age. This means these tests can give false positive results. Despite this limitation, non-treponemal tests serve an important purpose. They're used as rapid screening tests. They're inexpensive, easy to perform, and give quick results. They're particularly useful for screening large populations, such as in prenatal clinics, blood banks, and STI screening programs. Another valuable feature of non-treponemal tests is that their antibody titers correlate with disease activity. The antibody levels rise during active infection and fall after successful treatment. This makes them excellent for monitoring treatment response. After successful treatment, the titers should decrease by at least fourfold within 6 to 12 months. However, because of their non-specificity, any positive non-treponemal test must be confirmed with a specific treponemal test before making a definitive diagnosis of syphilis. Now let's discuss treponemal tests, which are the confirmatory tests for syphilis diagnosis. These tests detect antibodies specifically directed against Treponema pallidum surface proteins, making them highly specific for syphilis. Unlike non-treponemal tests, treponemal tests detect antibodies that are produced specifically in response to treponemal antigens. This makes them much more specific. They're far less likely to give false positive results from conditions other than syphilis. Several treponemal tests are available, each using different methodologies. The FTA-ABS test, fluorescent treponemal antibody absorption test, was historically the gold standard confirmatory test. It uses indirect immunofluorescence to detect antibodies bound to kill Treponema pallidum organisms. The MHATP test, microhemagglutination test for Treponema pallidum, uses red blood cells coated with treponemal antigens. If the patient has antibodies to Treponema pallidum, they'll cause the cells to agglutinate. The TPPA test, Treponema pallidum passive agglutination test, is similar to MHATP but uses gelatin particles instead of red blood cells. Enzyme immunoassays, EIAs, and chemiluminescence immunoassays are newer automated methods that can detect both IgG and IgM antibodies against Treponema pallidum. These are increasingly popular because they're easier to automate and can process large numbers of samples. The key point about treponemal tests is that once positive, they usually remain positive for life, even after successful treatment. This means you cannot use treponemal tests to monitor treatment response or to distinguish between active infection and past treated infection. They're purely confirmatory tests. The typical diagnostic algorithm is to screen with a non-treponemal test, VDRL or RPR, and if positive, confirm with a treponemal test. However, some laboratories now use reverse screening, starting with an automated treponemal test and confirming positive results with a non-treponemal test. Each approach has advantages and limitations. Finally, let's discuss how we treat and control syphilis. Penicillin remains the treatment of choice for syphilis at all stages. It's highly effective, and Treponema pallidum has not developed resistance to penicillin despite decades of use. This is remarkable and fortunate. The specific regimen depends on the stage of syphilis. For primary, secondary, and early latent syphilis, a single intramuscular dose of benzathine penicillin G is curative. For late latent syphilis and tertiary syphilis, except neurosyphilis, 3 weekly doses of benzathine penicillin G are recommended. Neurosyphilis requires intravenous aqueous penicillin G for 10 to 14 days due to the need for higher drug concentrations in the cerebrospinal fluid. For patients with penicillin allergy, alternative antibiotics include doxycycline, tetracycline, erythromycin, or ceftriaxone. However, these are considered second-line options. For pregnant women with penicillin allergy, desensitization followed by penicillin treatment is often recommended because penicillin is the only antibiotic proven to effectively treat fetal infection. Controlling syphilis requires a multifaceted public health approach. Safe sex practices are fundamental. This includes consistent condom use and limiting number of sexual partners. However, it's important to note that condoms reduce but don't eliminate transmission risk, as lesions can occur in areas not covered by condoms. Sex education is crucial for prevention. People need to understand transmission routes, recognize symptoms, and know when to seek medical care. Contact tracing and treatment of sexual partners is essential to break the chain of transmission. When someone is diagnosed with syphilis, public health authorities work to identify, notify, and treat their sexual partners. Standard precautions in healthcare settings protect healthcare workers from exposure to infectious lesions and blood. Unfortunately, despite decades of research, no vaccine for syphilis is currently available.